it's immense pleasure to introduce our moderator, Dr. Sanjai Addla. He is a consultant uro-oncologist, Apollo, Hyderabad. I would also request my panelists to come over. Dr. Genil Kumar, consultant uro-oncologist, Amruta, Cochin. Dr. Manav Suryavanshi, consultant urology and uro-oncology, Amrita Hospital, Faridabad. Dr. Aditya Pradhan, consultant urologist, BLK Super Speciality Hospital, Delhi. Dr. Tarun Jindal from Narayana Super Speciality Hospital, Calcutta. Dr. Tongaonkar sir, sir is a director of oncology and geo-oncology, Max Hospital, Nanavati. Dr. Animesh Saha, radiation oncology consultant from Apollo, Calcutta. Dr. Suparna Rao, medical oncology consultant from PD Hinduja Hospital, Mumbai. And Dr. Aditya Agarwal, Paras, radiation oncology consultant, Paras Hospital, Gurugram.
Good morning. Thank you very much for this opportunity. I haven't criticized any of the papers. I just wanted to know what are the take-home messages. That's one. And what can we do trying to implement any of the knowledge that we have gained for Indian scenario. And if I'm going to cut you short, please, there is nothing personal. We just want to finish all the 6 papers. So I've got 5 eminent uro-oncologists and 3 radiation oncologists. So I'm just going to start off with the only professor who is here. Then we should kill Ganesh Bakshi. He didn't know. You are Suparna Rao. Okay. Even in that one, it said radiation oncologist. I Googled all of you to know who you are. Okay. So you might get some bouncers. Don't worry about it. Okay. Ginil, we can start off. Null hypothesis. This is the starting statement of this paper saying patients who have the same disease grade but were diagnosed with that grade of disease at 2 different time points, diagnostic versus confirmatory biopsy, have similar outcomes after radical prostatectomy. Do you think that is right? Do you think they can prove that? That was the basic null hypothesis they started of the study from.
So they were telling that actually in the later stage they may be having the patient who had a biopsy later may not be having the high risk factors like that may encounter in the primary biopsy, like when they are doing the biopsy in the initial stage.
So this study was the Gleason. So these were low risk prostate cancer patients who were on active surveillance, who were on follow-up biopsy, were found to have intermediate risk features, went on to have radical prostatectomy. So they compared the patients who were intermediate at the outset to the intermediate at the confirmatory biopsy, and they say that both of them behave the same.
So they were telling, but thing is the outcome, they were telling that the long-term outcome was similar if those to the active surveillance if there was a delayed pickup.
Okay, I'll do the other way around. Do you think that is the correct statement or not? Do you think they will be able to prove the null hypothesis, or the null hypothesis will be disproved?
I don't think that with this paper it will be confirmatory. We can say that this can be done.
Okay, so you think that they won't be able to prove the null hypothesis? Pradhan sir, any comments on that?
Sanjay, there has been before this also some data on this matter.
We are going to come to that.
Yeah, so in this paper actually this is an inviting concept that if you have done a prostatectomy probably 6 months apart in similar pathology, you would expect actually the outcomes to be similar.
Yes.
That is the null hypothesis, and it makes sense if you're dealing with the same pathology, low grade, with a 6 months difference in time, probably your result should be the same. That is
the only difference for me in my understanding is the one that you picked up the second time took more effort from you to pick up.
Agreed.
Yes? Yeah. That's the only difference.
That's the only point.
Okay. So these were intermediary, they were all similarly matched up. The only difference is that the MRI didn't play that big a role in the initial workup. So if you try to implement that now, you would just say that MRI would have picked up all these things. Yamana.
So my contention is MRI was always the confounding factor in confirmatory biopsy.
Yes.
Because it was done in 62% of the patients. And that would change the course of the way we were approaching both these groups.
How would it change?
Because in MRI, you're picking up a Gleason grade 2, and we are not sure this is correlating with the higher pathology. On a pyrite scoring, the
Yes.
correlation of a Gleason grade 2, is it same vis-a-vis the histopathological correlation is open to...
Yeah. Agree with that. So there would be, that's what I was saying. You have put in another extra step to pick up the same thing,
So
and that
the,
would
the
alter
comparison is not a fair one between both the groups.
Yes. Okay. So if you look at this is what I was trying to get at, Ginil. If you look at the active surveillance group to the immediate RP group. So just to start off, these were 2 intermediate risk prostate cancer group who were diagnosed at the outset or following confirmatory biopsies. So the question is, do they behave the same or do they behave different? Okay. The null hypothesis was that they behave the same. So here, if you look at it, the patients who underwent immediate radical prostatectomy, there was a higher, we can all look at the statistical, there was a higher proportion toward, they had a larger volume of disease, the ones who underwent radical prostatectomy at the outset. And if you look at the lymph node invasion as well, 7.8 versus 2.6. So that itself is giving you an indication that somebody who lets themselves out to be an intermediate at the outset are slightly different. Yes. So, yeah, okay. Is active surveillance still relevant in 2023? Yes or no?
Yes.
Why?
So I would say there's still, there is the data which is maturing up, and there is data available saying that active surveillance can still be done in fair number of patients, specifically in the GG1 in which this particular study was.
So this paper came, and I don't need to tell you which, this is the PROTECT paper.
PROTECT paper.
15 years, 17 years. So all the newspapers said there is no role for radical prostatectomy. They didn't go into the minor picture of it. How will you convince somebody puts this in front of you and say prostate cancer survival at 17 years? You can't even see there are 3 lines. There is only 1 line there. And then you say that, oh, metastasis-free survival is different. How come metastasis-free survival is different, but overall survival is the same? Any comment on that?
See, every metastatic patient, the OS will not vary in the sense that even if the patient develops metastasis, it is not mandatory that this particular metastasis is going to have a culminating effect on his OS. So I believe OS probably is going to remain the same. It depends upon the pathology of the disease per se, but metastasis will not probably determine the OS.
There was the 10-year data, then there was a 15-year data. They looked at the patients who were diagnosed with metastasis at 10 years. None of them died by 15 years. So just the fact that they have metastasis doesn't mean that they die of it. That's one. And then the second is, this is the same point that I was trying to make. These patients have an indolent disease. They do happen to have metastasis. They are not same as de novo metastatic disease, the ones that present as metastatic. Manu.
So I also want to tell you something. The patients will not die of their metastasis because this is such a slow indolent course that the overall survival does not vary because they're going because of other causes and natural age-related progression causes in many subset of patients.
Yes and no is the answer. We always think that by preventing metastasis-free survival, by improving metastasis-free survival, at some point we'll improve the overall survival, but they might not live long enough to realize that benefit.
The duration of your lifespan.
Okay. Active surveillance, what are the components if you're going to put a patient for active surveillance? You have a grade group 1, 70-year-old has got medical. What are all the things that you're going to look at? PSA?
Yeah, there is, if there is more of an indolent disease like less PSA.
No, you have decided to put the patient on active surveillance. I don't
So
want to ask
PSA
why.
every 3 months we assess.
Okay,
Then,
and why
at
are you
18
doing
months,
the PSA? What would be the trigger for you to go for radical treatment? PSA doubling time or PSA density or what?
Actually, I depend on the repeat biopsy and the MRI finding.
No, I'll come to that. So you were doing a PSA, yes?
So,
Anything on the PSA that would make you change
so
your
if it
mind?
is a increment of PSA on follow-up, like 0.75,
So upward rise.
yeah, upward rise,
Okay.
then I will reevaluate.
MRI, how often?
18 months is usually my protocol, but
So 0 and at 18
18
months.
months, yeah.
Okay. Do you do standard repeat biopsies?
I usually do standard biopsy at present.
When would you do it?
At 18 months usually if I'm having a follow-up.
So
MRI followed by a biopsy.
3 monthly PSA, at 18 months an MRI scan and a biopsy. Even if there is no progression on PSA or MRI scan, you would still do a biopsy?
At present, I am doing probably MRI may substitute later, but at present,
Hemant
I
sir,
don't.
do you think that's an acceptable one, or do you think that's too laid back or too aggressive?
First of all, let me say that I'm not a great proponent of active surveillance. Yes, there is a place today, and as Ginil very rightly said, that you need to monitor the PSA as well as the biology, the repeat biopsies. I'm not very sure whether if your PSA is remained in the same range and everything else is fine. Whether I would
I'll do this way. Okay.
But
You are not a big fan.
I have been doing at 12 months, not 18 months.
Okay.
I repeat the biopsies at 12 months.
Okay, 12. So you do PSAs every 3 months?
But I don't give too much importance only to PSA.
No, it will always be a
It's
multifactorial.
only a trigger to do the biopsies.
Okay. So you do, if the PSA is going up, you won't operate based on the elevated PSA, you want a confirmatory histology.
Yes.
Okay? And you would do an MRI scan at
MRI,
12 months.
yes.
Overall, we are fine with 12 months. Manu.
So in my practice, a biopsy would be triggered depending upon PSA doubling time and MRI. Otherwise, I may not trigger a biopsy even at 2 years.
Okay. Fine. So I think if I ask the same question in 6 months' time, our active surveillance protocol changes. The PROTECT also kept on changing what the protocol is. Depending on PSMA might come into this and destroy everything else and say, do 6 monthly PSA, PSMA, it will give you all the answers. But active surveillance, the 3 components are PSA, MRI scan, biopsy, variable indication for the biopsy. Okay, we have already answered this. So this is what they found. When you look at the immediate versus the chances of biochemical recurrence is higher with the immediate compared to the ones that were intermediate on the second biopsies. Okay, and my understanding is, as I said, that's what was my understanding. Okay, I'm going to ask each of you. I'm going to put 2 scenarios. Which one of them is worst? Okay, the first biopsy is positive or the second biopsy is positive. Overall, who might do worse off? Pradhan sir. The first one would do worse. Even if they have got both Gleason 3+4,
Yes, and on
the one who
equivalent
was
grades,
diagnosed,
the equivalent grades, you picked up the one right at the outset. He has probably.
he would do worse.
He would do worse.
Agree with that? Gleason grade group, this is what we were talking about, in that the ones that are picked up to be Gleason 2 or 3 at presentation are worse compared to the ones that are picked up later. Okay. Does anybody can take up, does Gleason grade 1 transform to, you have done full mapping, 70 core biopsies, there are only Gleason grade 1 in 2 or 3. Will it transform?
No, I don't think. These are the cancers which are missed in the first biopsy. I don't think they have transferred.
Okay. Any changes on that? I thought so. I thought so is my answer. They can. So it is an acquisition of a mutation.
I understand, but it's too soon.
No, I'm
Confirmatory
not
biopsy.
saying time period. I didn't say time period.
Okay, I thought in this particular
No,
study.
I
with
didn't say, I
12
just
to
said,
18 months,
I
you
didn't
don't
say time
expect this.
period.
Yeah.
Yes. So somebody who can have Gleason grade group 1 can acquire a Gleason grade group 2 or 3 at an later date. Okay. Intermediate risk on biopsy or intermediate risk on RP? Which one has got better prognosis?
I would say probably an intermediate risk on an RP. would
RP.
probably-
Because the biopsy said low grade, but the RP said. So I think the further the time we spend with the patient, which will give us the truth, probably is a better prognostic and compared to everything being known at the beginning. Just because of the volume of the tumor, you will know the truth at the beginning.
Because there is around 40 to 50% upgradation in RP specimen compared to the biopsy. So that is also a factor.
So this is the basis for the radical prostatectomy versus Gleason score. So whoever is intermediate or high risk on the radical prostatectomy compared to the biopsy, they tend to behave like their diagnostic risk factor rather than the pathological risk factor. You do need to take the pathological risk factor into consideration, but they do behave like the risk stratification at the outset, not at the end point. So that's the reason the DMECO always sticks at the beginning, not later on. You can't alter it. Okay, so take home messages from that one is the more effort you put into diagnosing a patient, the better is the prognosis for him. Okay, so this one all about radiation oncologists and the one alone medical oncologist. This is the PACE A, B, and C. There was one surprising thing which the radiation oncologist missed, but I'll just try to point out. So here, if you see the low and intermediate risk, surgical consideration, the moment it went from intermediate or high risk, there isn't any plan of offering surgery there. That means that actually none of us would be doing any surgeries if we were living in this country. They didn't offer surgery as an option to those patients. So only in low and intermediate risk, which we can say patients who didn't need anything done, were the only ones who were offered surgery or radiotherapy. And anybody intermediate or high risk, they were said 6 months of ADT. But anyway, we are looking at this element, which is low or intermediate risk, the PACE A, comparing SBRT to prostatectomy. Okay? These are the numbers. They wanted to do 2, 3, 4 because the numbers were 2, 3, 4. They ended up with 1, 2, 3, which I thought was quite coincidental. Why SBRT? Why is it different to radiation other than the convenience to the patient? Anything else? Is it oncologically better?
So the radiobiology when we do SBRT is different as we are giving a higher dose per fraction. And as prostate has a low alpha by beta, so it is known to multiply very slowly. So a higher dose per fraction would work better for prostate. We want to escalate the doses to prostate, which would happen more conveniently when we do SBRT.
So the bothersome symptom score has already been explained. I don't want to go further into it. I'm going to come back to you. The next question. Pad usage at 2 years of 46.9%. Either of you can take it. Yeah? And anyone can take it.
The pad usage at
2 years.
2 years is 46 is too much. Like in our practice, we had published this one. It was around 12 was the pad usage, and out of it, more than one was 3 in our.
Hemant sir, what do you think is an acceptable number of more than one pad usage at 2 years?
At 2 years, I would say 10% or less.
Okay. I'm going to point towards both the radiation oncologists. If you just look at this one, this is the hood technique for preservation of the continence. Nothing to do with you, but something to do with the surgeons. So this is a new technique that we are trying to do. And when a patient comes to me, should I tell them these numbers? So the numbers are at 1 week, 20% will be pad free. By week 48, 95% will be pad free. Because I have read the paper, can I quote those numbers?
No, I don't think.
Why can't I quote those numbers?
See, because surgery is skill based, so if you're not doing it really, you might not achieve them.
Good. That's a learning curve for the surgeons. Okay. Is there a learning curve for radiation oncologists? You will quote those numbers to me and say that patients are pad free at 2 years. There isn't any learning curve for radiation oncologists?
So there is a learning curve for each and every one where skill is concerned. So there is a learning curve for radiation oncologists as well. And looking at this data, looking at this paper, no radiation oncologist would jump and say, I will start doing it tomorrow in their practice. Okay. SBRT, for that matter, is not a very new technique. We've been doing SBRT at multiple sites. So we understand the nuances of SBRT. It's not like doing a surgery in head and neck and doing a surgery in prostate would be absolutely different. But doing SBRT in prostate and doing SBRT in pelvis would be quite similar.
Doing a radical prostatectomy with hood technique, I would say, is similar as well. Okay. For radiation technicians, is there a learning curve? If I'm starting off as a radiation oncologist?
Yeah, I think that there is definitely a learning curve. And we have, as Madam
How
told...
would you know you have gone past the learning curve?
So
you might still be learning. You might be senior consultant radiation oncologist.
No, there are definite protocols of contouring. So we know with the advent of newer imaging techniques like PSMA PET, MRI, we know what to contour, what to treat. what margin we need to use for the PTV, what margin.
The
we
last
need
question.
No, no, so I'll
And
just add to it.
there are definite image guidance
No,
protocol that we
I'm
follow.
a patient, I need radiation for something. How do I know somebody is good among radiation oncologists? If I go to Hemant sir and said, what is your margin positive for T2? He gives me a number, I know.
So I give my toxicities that I have with patients. Now, as you said, there is a learning curve for a new technique. For SBRT, if I start doing it in my practice, I would take some time to build up that data, but even I would have that data of toxicity for my patients with that technique.
So if you have a patient, you were giving SBRT for... Yes, sir.
Data, that can be definitely a discussion. But otherwise, when we have been part of these group studies, RTOG, you get fed up of sending the data, the kind of data they ask for. So they do have a huge quality control. But it is a fair question that how do we implement it and how do we talk about
No,
it?
the reason is both medical oncologists that Vamshi is going
So
to be.
again, Dr.
I'll ask the question, then you can. Like when they say, oh, docetaxel, they'll say that, okay, the survival benefit is 12%. And they ignore that there might be a mortality chance of 1 to 6% depending on, I'm just exaggerating the numbers, depending on the experience of the center. We ignore the second part, we only quote the first part. Now you can.
Simple way to do it is through an audit. And that is something which any good radiation center will do. They have their own audit. Our center does an audit every day for all their patients. So that's one way you know that what they're doing is the correct thing. Second thing, there's always the, like sir is saying, the data on the machine is stored. You can't fiddle with that data. It is the data which is needed.
No, apart from that, there is a lot of standardization of what we draw, what we treat, and what we achieve in a plan. So we know what toxicities we will get if we are achieving something for an organ.
Good. If I made a radiation oncologist a bit angry, I've asked the right question. That study was sponsored by Varian. I totally agree with the trial setting. If I wanted to be involved in a trial of radical prostatectomy, Ginil would not take me unless I provided the data. I'm not talking about if I want to get to anybody, how do I differentiate? That was the question. So for clinical practice, I was asking a question. Okay. Yes. Yes.
He's talking about a
No,
different
it is.
paper.
No.
That wasn't the question. That is taken for granted. You are not operating. Of course, the patient will be continent.
No, but and as per the other studies also, like phase 3 itself, the pad usage and everything, the geotoxicity was very acceptable.
No, it should be minimal, as you would expect, because you are not operating.
Yeah, it is minimal. So when we compare surgery and SBRT or radiation for that matter, the pad usage has always been lesser with radiation.
110%. I'm not even questioning that.
I think the question is not that. He's questioned the fact that 46% of patients used PAD at the end of 2 years.
2 years of surgery. That was too
Which
high.
is not acceptable by today's standards.
That was the question. Because there were quite a few laparoscopic radical prostatectomy done in that. Okay. So we'll come to this one where everyone... Sorry? Yes. 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 Yes.
What is the number of surgeons performing robotic or laparoscopic radical
As I said,
prostatectomy?
I wasn't criticizing the paper. It wasn't a journal club criticizing the paper. I just wanted to learn from whatever I can learn from it. So that's why I've read the paper, but I didn't want to even look at those elements.
So, but can I make a comment on this paper? Just a small one.
Yeah, sentence.
So the ADT is not permitted in low-risk patients in
Yes.
this paper. active surveillance could have been offered.
Yes.
So the effects of ADT and side effects are totally taken away from this paper. They're
I
not
would
worried
do the-
about giving the oncological outcomes which will come after 6 months. They're presenting only a smart frame of the paper. They're not presenting a wholesome paper.
Yes.
It's just one frame in the journey. So they should have presented a complete outcome analysis along with the side
That
effects.
is going to come.
Yeah, it's going to come. They have
But
only
they should have
presented
given
what
it
they have.
together. They're giving a low-risk patient which should have been offered active surveillance.
Let me add to, again, coming to SBRT, because one of the study was done at Tata Hospital, done by Vedang was the PI, it is in JCO. See, I think so efficacy data is there in,
Yes.
intermediate situation. No one is saying that option is not there.
Yes.
So I think so that is, option is there, and how to take those options in the clinic, I think that's what I think
Yes.
Sanjay is trying to put in, and it's absolutely wonderful data.
The way I wanted to look at it is, if a patient asks for an intermediate risk prostate cancer, wants to have SBRT, how do I know somebody is doing a good job? That's the question that I wanted to comment.
Quality control, what people are putting in the place. Sanjay says the way I do it, you need to also do in radiotherapy side.
Sir, so, no.
Come to that.
Just, let me.
I will park that question. I'll park that question and come back to it later. So, neoadjuvant novel hormonal therapy.
I think what he is saying is absolutely right.
That's
you should
right.
choose your surgeon.
Even-
But, yes, probably the quality of surgery in this was very, very poor.
I understand that. That wasn't the.
See, 50 surgeries over 10 years.
Hemant,
of
sir.
time.
Yes, I'll leave it there. Okay, so neoadjuvant novel hormonal therapy. As I said, I wasn't criticizing the paper. I was just trying to understand the take-home messages from it. Neoadjuvant novel hormonal therapy. This paper has been published. So I was looking at what are all the evidence basis and what are we trying to do. So the way they compared it was there were 3 studies that were randomized controlled trial for the neo-hormonal agent. Then they compared it to retrospective radical prostatectomy group. And as they said, it is better. So they only gave it for 6 months. It was only neoadjuvant, that's one. Then all the patients I had to read again and again. They didn't mentioning about ADT. Only when you went to the previous trials, you realized all of them had ADT and newer hormonal agents for 6 months, did not have any adjuvant. So just with 6 months of ADT and newer hormonal agents, that is the impact. Okay, I reiterate again, none of them had 24 months of ADT. They had 6 months of ADT and newer hormonal agent. And if you see, the effect of it seems to be there even at 6 to 8 years. I don't know why that effect is there, but the effect is there for that long a time period. Probability without BCR. I would have probably put a testosterone level somewhere in there just to see when does the testosterone return to normal, so that we have altered the biology of the disease rather than just the testosterone suppressing it. But by 6 months, you would expect that by 9 months, the testosterone would have come up. And this is the metastasis-free survival. Is that a good enough? Currently, we are using in a short-term study, metastasis-free survival. We say it's a surrogate marker for overall survival, especially when the difference is so much. Okay? So this is what they have said. They have achieved a PCR and MRD of 22%, decrease in the margin positivity as well. Manav, that's cheating, isn't it? The second statement. You're using a drug to alter the pathology and then saying that I'm better.
So, but then you are basically going on a multimodality thing, then it's again not a fair comparison between both.
Yes. No, as in it makes us feel good that we are a good surgeon, but I would take it with a bag of salt and say, let's see how you are in 6 months' time.
Sanjay, can I make a comment?
Yeah,
here?
Madhis.
So first is, this is not a randomized trial.
Yes.
This is an observational study.
Yes.
The second is that, what they have used in terms of this IPTW kind of weightage, they have tried to match non-similar kind of groups. So whatever you actually score out in the end is probably heavily biased. Because
I totally take on, it's a proof of principle to say that it does tend to alter the way we are treating. That's it.
You can't,
Nothing more.
You can't draw any inferences beyond this.
Nothing more.
Okay.
So better than a case series, but nowhere near any randomized control trial.
RCT that was there, the phase 3 trial with docetaxel again did not
Yes. But the issue was that docetaxel would not work in that setting, and they have given normal hormonal agents. So normal ADT with docetaxel. So probably the combination that you were giving did not alter the intracellular androgen status. I agree with that. It's just that the docetaxel and ADT was appropriate at that time. This is what is appropriate for now.
So I'll make one comment on that paper. So this is basically a paper on high-risk prostate cancer, by definition. And if you see the need of adjuvant or salvage radiotherapy in the paper, the standard arm, you see 70% patient needed adjuvant or salvage radiotherapy. And in the study arm also, about 41% patient needed adjuvant and or salvage radiotherapy. So we are going to multimodality treatment, neoadjuvant therapy with abiraterone, then surgery, then radiotherapy, and you are adding up the toxicity of all these modalities.
I would do that. We are adding up the efficacy element as well.
So my point is, why not just treating them with the standard radiotherapy and adjuvant deprivation therapy and avoiding surgery in this patient?
I would say the same thing like Stampede, wherein why give docetaxel at the beginning, wait until they relapse and then give docetaxel. I know that's a crude exaggeration. We are trying, I'm just trying to prove a point to say that this is probably the way we are going to treat in future. This isn't a randomized control trial like any of the ones that we have studied.
I read one comment, Sanjay, when I was going through this article by one of the editorial comments. And these protease which has been quoted.
That won't give us the answer.
What has been brought out by that comment is that probably we have no randomized data. Even in this protease, the placebo, so-called placebo, actually has hormone deprivation. They are on leuprolide, and then you've added APA to that. So you don't have a blind placebo, you non-treated placebo. So
actually you need 3.
You need a patient without any ADT.
Radical prostatectomy plus ADT, radical prostatectomy plus ADT, and neurohormone.
Has disapproved
this
kind of a trial, saying that the placebo cannot be an ethical issue.
One of the other parameters that has to be studied is the chance of not getting a hormone in lifetime, because that is where actually a multimodality treatment may find difference.
Sanjay, just adding one more,
Yes.
because there was a comment regarding giving 6 months and benefiting at 15 years, 15 or 7 years, whatever. Many adjuvant trial is there where we give only for 6 months chemotherapy. Benefit is at 30 years also. So it does happen. There is another very good example. That is intermediate grade glioma. Given treatment for a year, benefit starts at 7 years. Till 7 years, no benefit. And after that, the benefit continues at 15, 20 years. And 3 NEGM paper on that. So idea is that when you give treatment, when you have effect, by tumor-wise, things changes. Not necessarily it remains what we think.
That's an excellent. What I was trying to say was, rather than masking the effect, probably we are changing the tumor biology. That's what I was
I totally agree with your interpretation. New adjuvant, if you're doing surgery, do good surgery.
Okay. So agonist or antagonist, what would you use, Hemant sir, as ADT? Which one would you use? There wouldn't be any evidence. What do you use in your practice if you were using it?
I will use an agonist here.
You would use an agonist. Yes. You would not, or would you?
I would, except in certain cases where the high-risk cardiac cases.
No, okay. I'm talking of
as a routine.
No, I'm talking of neoadjuvant before you do a radical. You are inspired by this study and you say, I want to practice this.
Yeah, as a routine, I don't give neoadjuvant hormonal therapy, but if at all, then I would give agonist. I will not be inspired by this study at all.
Anyone else changes?
I sometimes, in patient with impending bladder outflow obstruction, I tend to use antagonist.
Okay.
I don't use it as of now, but yes, there have been literature saying that antagonist may be slightly better because the surgery, the kind of post-op, the intra-op adhesions that you have with the agonist are not there with the antagonist.
Would you use AAP or ENZA? Which one would you use?
I'm using abiraterone at present, if at all I am using it. But thing is, I am not a fan of neoadjuvant hormones. At present, there is no data, but we have to have some trials.
Okay. Mano, would you use enzalutamide?
You are asking the question about neoadjuvant. So I would use AAP.
Okay. So you would use AAP?
Unless it's contraindicated.
Yeah.
Because there's one paper which says possibly if a sequence is to be done, then ENZA acts after AAP.
So agonist or antagonist? Which one would you use, Manu?
Antagonist.
Agonist. Antagonist. Okay. Apalutamide, darolutamide. Which one would you use? If you had the option of either using abiraterone, enzalutamide, apalutamide, or darolutamide.
I would go with the simplest, Abby. I would go with Abby.
Okay. Docetaxel chemo, we already know. Medical oncology doesn't work.
This is all in neoadjuvant setting.
All in neoadjuvant. And how long neoadjuvant? 6 months is fine?
I would believe even 3 months is fine.
Okay. Triplet therapy here. What do you think about that, Adis? Neoadjuvant triplet therapy.
But why 3 months, may I ask?
Sorry?
Why 3 months?
Because there has been a randomized trial comparing 3 months versus 8 months of neoadjuvant.
Yes.
And only in the 8-month arm, there was some difference in the pathology.
Yes.
So Sanjay,
So in case you want to do that, achieve that, then 3 months is inadequate.
Okay.
man.
Yeah, go ahead.
Triplet, you'll have to target, you'll have to tailor what you're doing. If
Okay.
you're dealing with a very high
I'm
risk,
just saying,
triplet.
in the future, do you think we'll come to triplet?
I doubt it.
Okay.
I doubt it.
Hemant sir is vigorously shaking his head.
I think so. I think the way things are
Neoadjuvant
going,
followed by
yes.
adjuvant,
I'm not too
like
sure.
they do in
Not too sure.
radiotherapy people. So that nobody knows the truth
No,
for 2
before
years.
surgery, I think only neoadjuvant. I wouldn't say.
Okay. I'm going to skip the Retzius pairing because none of the medical oncologists or radiation oncologists would be interested. Okay. This one, I'm just going to ask, is this relevant for India? The reason why I was asking that question is we haven't proven a point that EPLND does anything. We pick up a lot, but it doesn't seem to make a difference with respect to the overall survival. That's one. Second, picking up an extra one node that is in the pararectal space surely won't make a difference if that is not making a difference. And then the third one is, where does PSMA PET sit? Because none of these guys have got access to PSMA PET. So I wanted to answer the question difference between this one and PSMA PET. Aditya sir.
See, PSMA PET, obviously high sensitivity, low specificity is the crux of the PSMA data. High sensitivity, low specificity.
Yes.
So for us, with the easy availability of PSMA PET, trying to get into this would probably take a lot of effort, and maybe only a few centers who are doing a trial would go for this.
Okay. So you would say I would do EPLND guided by PSMA PET. Okay. So so this one I just wanted to show the numbers here. If you see the sensitivity of this is 95% specificity. As you would expect, it's a pathology, it will be 100%. Negative predictive value is 99, positive predictive value is 100%. Answering your question of PSMA PET, these are the numbers. So when you look at it, you said sensitivity is high, actually it is. So positive predictive value is 67, negative predictive value is yes. So the PSMA PET probably is somewhere in the middle for us, and when I looked at the methodology of trying to get that lymphoscintigraphy, again the learning curve with that, I don't think we'll ever reach in the normal setting. Mana.
Can I make a small comment?
Yeah.
This is a good concept, but you add a truss injection the last night, you add a lymphoscintigraphy, you add a SPECT CT scan and the expense to avoid 2 centimeter extra of sampling of lymph nodes, and to try to prove that we are avoiding lymphoseal, which I have not had in more than 1 or 2 patients in last 1,500 patients over last 12 years.
So that's why I said it wouldn't. Currently, the sentinel lymph node for prostate cancer doesn't seem to work just because
As a
of the
concept,
logistics.
it's fine.
Yes.
I agree.
Yeah, agree with that.
Just a comment
Yes, sir.
about this PSMA. Basically, the thing is, which PSMA agent is this? There are multiple PSMA radioligand.
Gallium-67 is currently the standard unless mentioned.
It is used in the US. So this is a 2019 paper. The gallium was licensed only in 1st December 2020. So this must be fluctuating.
That's an Australian one.
It's Australian.
That's an Australian. Almost all the groundbreaking PSMA work is done from Australia. Yeah, you have then we'll have 2 minutes of this last one, and then we are done. Yeah.
Just to make a comment as a radiation oncologist. So when we are treating high-risk prostate cancer, we've got data
Comment.
from POP-RT trial that pelvic RT versus prostate-only RT.
Makes a
Pelvic
difference.
RT
Pelvic
makes a
RT is the
difference.
standard.
That's why I think elective pelvic lymph node dissection still hold promise, even if it is negative on the sentinel lymph node?
No, no, okay. We already know where to do the EPLND. Yes, we do it, but we still don't know why we are doing it because we haven't shown any survival benefit. But as oncology surgeon, we would like to prognosticate the patients better. That's why we do it.
From the radiation perspective, we have got the benefit that treating the pelvic node do benefit in patients,
Agree with
even
that.
node negative patients.
Agree with
high
that.
risk patient.
Agree with that. So this one, though, when it was presented, they said there might be bias. Actually, the way they randomized it between RT alone and short hormonal therapy RT, they had 3 randomization, but each center could only randomize using one of these. They were not offered more than 1 randomization at center. So there was no bias at that center. So if you look at this RT alone plus short-term RT, which was 6 months, this one short-term RT versus long-term RT, and then there is the 3-way arm. And I was, okay, so this is one. Short arm doesn't, so either give ADT for 2 years or don't give ADT. That was my take-home point. And this one is between short and long arm, the metastasis-free survival is better with the long arm. Then there was this sentence. So conclusions were this. Then there was this sentence. Dr. Parker, who was presenting this,
That's a very important.
said, so the other one wherein no hormone therapy to long arm hormone therapy, which was one of the arms, when they studied it, there was no difference. So there is no difference when there is no hormone therapy to short arm hormone therapy. There is no difference between no hormone therapy to long duration hormone therapy, but there is a difference when you use 6 months to 24 months. So again,
So is the short arm causing some harm?
some way. It's like using the zoledronic acid in any of those monthly ones will lower it rather than doing any better. Okay? So take home messages, whoever presents early with intermediate disease, they are worse compared to later on. Compared to surgery, all the radiation oncologists, SBRT is better. That's the last time I'm going to say it. SLND is the effective method, but probably not practical. Using the neo-hormonal agents, I think we will be revisiting this space. Probably they'll be using this more in radiotherapy before we even use it in surgery. Immediate continence recovery rates were better with Retsia sparing at the cost of having higher margin positivity. And if you were using ADT with salvage RT, use it for 24 months. I asked one of our Manchester medical students what this meant.
Thank you.
They had various versions. That is, the art of providing care is very long and the life is too short to get to them. But anybody can read anything into it. Thank you very much.